Have you ever gotten in the car and just started driving? Like not knowing where you're going, just let's get in the car and drive, see, where we end up, what we encounter along the way. Like that, I think that sounds like it could be a fun day if you like car rides and you're with a person that you like to ride in the car with, right? Maybe like a Saturday, hey, we're going to just drive towards the beach, but still we have a destination in mind, right? But I think the thing is if you're trying to reach a certain destination, say you are driving to the beach or you're driving to a city or a specific place, there's a few things you need to know. So if you don't know how to get there, especially, right? You've got to know where you're starting from, right? When you put when you're getting your directions in your Maps app on your phone or whatever you use, you're going to put your starting location in. Then you're going to put your destination in. And then I think of when I pull up, right, it gives me these different ways. Do I want to go through the city? Do I want to go around the city? Do I want to avoid tolls? Right, there's all these things that we have to consider when we are going from point A to point B. And I think the thing is with hormone replacement therapy, a lot of women are just starting without ever having that conversation. And it's an important conversation to have, especially because we're in the new wave of HRT. We're going to see more and more women getting on HRT, which is amazing, and I love that. But there's conversations that need to be had so that we can make sure we're heading to our destination. So today I want to talk you through 5 things that you and your doctor you should talk about before you're starting HRT. And even if you're already on it, it's a conversation worth having. This is Her Genetic Edge with Lori Aikman, a podcast helping women make sense of hormones, genetics, and the midlife transition through practical conversations around health. This podcast is for educational purposes only and is not intended to replace medical advice. Please consult your healthcare provider before making changes to your care. All right, so you're on HRT or you're considering starting HRT. I think the first thing to consider, and this is something we do in my practice, is we consider what are your goals? Like right now, you might just feel miserable. You're like, I can't lose weight. I can't sleep. I'm having hot flashes. I have no sex drive. I'm, got vaginal dryness, whatever it is, right? You might feel miserable right now. You're like, please help me. And so it might just be that urgency could just lead you to be like, all right, let's just start it. Like, okay, yep, do the labs, or maybe your provider doesn't do the labs. Let's just start the HRT and get going. But I think something we need to consider is like, what is our goal? One, probably symptom relief, right? You having symptoms that are impacting your life and you want relief from those symptoms. So actually having a conversation with your provider about what your expectation is. So if I start this HRT, here's my goal. My goal is for my libido to come back. My goal is to sleep. My goal, right? Have an actual conversation about where you want your body to go and what you want to happen in your body when you are taking HRT. Because the one thing that comes to mind for me, a thing that I hear from a lot of women is, I can't lose weight. If I get on HRT, maybe I can lose weight. And unfortunately, it doesn't work that way. I know you might say I've like posted stuff on the internet on social media, and I've had women say like, I lost 10 pounds, and that is fabulous. I'm so happy for them. But if we look at like physiologically what like bringing your estrogen, progesterone, your testosterone up doesn't have a direct impact on your metabolism, right? We know that there's metabolic function involved, but it's not like, let's say GLP-1s that affect insulin and affect digestion, right? Those have a direct effect. I think a lot of times when women like quickly lose weight when they get on HRT, is there maybe some inflammation that comes down immediately, but it doesn't, it's not a weight loss drug, right? If you go to a weight loss clinic, they might help you optimize your hormones for sure. I know weight loss clinics that do that, or these anti-aging clinics, but know that that's a potential out there, I guess. That's a conversation I would have with patients. I would say, okay, you want to lose weight? Yes, let's optimize your hormones. But that might not necessarily mean that you're going to lose weight automatically, right? So knowing where you're headed. And there are maybe other confounding factors, right? I'm somebody in perimenopause. My sleep has gone out the window. I don't sleep through the night most nights. And when I get often woken up by kids in the middle of the night, I just have a really hard time going back to sleep. And there's other things involved in that. I know that I have just a easily stimulated nervous system where I have to do other things to help my nervous system. So again, a conversation for you to have with your doctor so that you have realistic expectations about how that HRT is going to help you. And so they know what other help you might need in order to achieve your goal. So let's move on to number 2. So number 2 is you got to understand the benefits of HRT. And this might mean something different than you're thinking. Like benefit, okay, of symptom relief, but there's other benefits of HRT that I think many women don't realize because they're just hoping that it helps them feel better. Because I hear women say things like, "I just want to take the lowest dose that I can," and I think that expectation or that drive is to avoid any potential risk factors. Okay, am I going to have any breast cancer risk or bleeding or these things that can come up? But the thing is, we have to look at how HRT actually improves our quality of life and our longevity. We have better data now that shows the earlier women start. So when women start HRT in perimenopause and they optimize those levels early rather than going for 10 years with like suboptimal estrogen before they finally get on estrogen therapy when they're having hot flashes, right? If we go ahead and start those women on HRT, even when they're still cycling, but they don't have normal levels of hormones, I'm in that boat right now. I'm 41. I have suboptimal levels of hormones, right? Optimizing those levels, we know has better outcomes long term. And the outcomes we're talking about are things like bone health, so preventing osteoporosis and osteopenia. So if you're in your 40s, for you, it might feel really far off of like, I don't really care about that right now. Like I exercise, I eat my protein, I'm fine. But I know for me, I come from a family of multiple generations of osteoporosis and osteopenia. So I know that optimizing my estrogen now, even though I'm having normal cycles still, is going to help my bone health long term, which think of how many older women, let's say women in their 70s, 80s, even 90s, have a fall, have a significant break, right? Break a hip, and grandma doesn't leave the hospital, right? They fall, they break a hip, their life, just their health declines from there. That's what we're talking about. And so we have to have that longer perspective in mind of like what HRT is also doing for us. So one, bone health. The second one is our brain health. This is also something that might seem far off in the distance, but I have women that come to me, been my patients come to me in my practice, and they're like, we have a family history of dementia. So my mom's had dementia. My mom has early dementia. My dad or my grandma, etc. Those are the women that are usually more motivated by this. We have a connection now, and there's studies that are showing what levels we have to optimize estrogen at to prevent this. But cognitive decline and risk for things like dementia decreases when we optimize those hormone levels, especially estrogen. So estrogen and progesterone has an influence there too. And again, that's something that later in life is going to affect your longevity and your quality of life. And then the third thing is then heart health. So we don't have as strong of evidence around this as we do for dementia and osteoporosis and osteopenia, but I believe there will be in the future, we'll be seeing more research done around this about the benefit of HRT and optimizing hormone levels to prevent heart disease, right? And heart disease is the number one killer in women. So these are three potential benefits that you would be missing out on if you were just taking just give me the lowest dose possible to just make my hot flashes go away, or to just make my symptoms go away. Yes, your symptoms have improved, but if your estrogen, I see a lot of women who are on estrogen, but their estrogen is 30, 50, where it needs to be 100 for that bone protection, brain protection, heart protection, right? You're missing out on that if you're not really optimizing those hormone levels for those long-term benefits. So that's something to keep in mind when you think about, okay, I want to go on HRT, and an expectation to have. With that, we obviously want to talk about number 3, what are the risks of HRT? I talked in the last episode about Women's Health Initiative and how in the early 2000s that scared a lot of women off HRT because they thought they were at risk for breast cancer if they were on HRT. Now we have that evidence has been reevaluated. We have seen that there are, the type of HRT matters. Your personal history does matter, your medical history, right? Things like inactivity, obesity, diabetes, things like that. When we have poor metabolic health, that also increases our cancer risk. But those would all be things to consider. Have other women in your family taken HRT? Has there been other hormonal imbalances in your family? I will a lot of times see a family history of uterine fibroids where, say the woman I'm talking to who's in her 40s has had an ablation for bleeding and fibroids and heavy periods. Her mom before her just had a hysterectomy, and probably the grandma may have had a hysterectomy too. And so considering, okay, is there potential hormone imbalances that could affect my hormone levels if I get on HRT? Looking at just your general health status right now. We also want to look for risk of things like clots. Is there a strong family history of cancer? Has there been hormone positive cancers in the family, right? Those would be things, probably a more nuanced conversation for some. Also, do you have a history of cancer yourself? That's a conversation for you to have if you've had a history of cancer, but your HRT symptoms but your menopausal symptoms are so severe that you want to do something about it, right? That's a conversation to have with your oncologist and whoever's managing your HRT. The other thing we want to look at is your heart health factors, right? Are you at risk for heart disease? Do you have a strong family history of heart disease? Have you had a history of blood clot? Are you a smoker? Have you been told you have, you have some plaque buildup? Maybe if you're somebody in your 60s and you had a coronary calcium scoring test and you did have some plaque, right? Those are conversations then where you need a multidisciplinary approach, right? You need to talk to your cardiologist and whoever it is that's prescribing your HRT, whether that be your primary or your OBGYN, things like that. And then the other thing to consider is looking at the risks of the type of HRT that you're taking. One thing to note, my preferred way to prescribe estrogen is topical estrogen. So estrogen that's either in the form of a patch that you put on your skin. You could also get compounded estradiol from a compounding pharmacy that's in a cream form that you can apply to the skin. You can apply estrogen vaginally. You can also take oral estrogen pills, but when you take oral estrogen, so when you take any pill by mouth, it essentially gets filtered through your liver. We call that the first pass effect. And when we take an estrogen pill and it undergoes that first pass effect, it can increase certain clotting factors. And we know that there's a higher risk for clot when a woman is on oral estrogen versus topical estrogen. So if you are somebody who has had, again, a history of a clot or a family history of clot, you have a genetic disorder that makes you more predisposed to clots, that would be a conversation to have of what is the safest route of HRT for you to take. Then I think the fourth thing to consider after that. So we'll recap. We've talked about your goals. We've talked about the potential benefits, especially those long-term benefits that are going to extend our quality and quantity of life. Then we have the third thing, understanding those risk factors. And those are going to be individualized. And then number 4 is going to be what to expect. Unfortunately, I see women where they get kind of put on HRT and they're on like a nice low dose and their symptoms have improved and the doctor says, okay, see you next year. I think when we consider that we need to, maybe a goal is you have a strong family history of dementia. I think whether you have dementia or not, I'd love to see every woman really optimize their estrogen levels specifically. But especially if you have a higher risk, just going on the lowest dose and never checking levels doesn't really give us that brain protective benefit, right? So what you often see is when you go on HRT, say you start estrogen and progesterone, they add in testosterone later, something like that. What you would expect is that they would recheck your levels in about 6 to 8 weeks. Check on your symptoms, check on your levels, depending on the provider. Even if your symptoms have improved, but your levels are still suboptimal, they may want you to increase your dose, monitor for side effects, and then again, check those levels and again in 6 to 8 weeks. So that's an expectation that you want to have, that when you start, it's not just set it and forget it. It's okay, we're going to monitor this, right? We're going to ideally get up to that therapeutic level for you, whatever that is. Now, the thing to know is that for so many, right, we kind of have this expectation of, I'm just going to get on it and all my symptoms will go away. And for some women, it does great and it helps. What I see is mainly in perimenopause, when a woman is just starting progesterone, like she can be like, oh my gosh, my sleep is so much better. I'm not anxious. Like I feel like $1,000,000 or I feel like myself again. Right. But more often than not, when we're titrating multiple things, right? We're trying to optimize progesterone and estrogen and maybe testosterone as well. It can take time to get to where you feel good on the dose that you're on and you're on the form that you're on. The type, is it a cream? Is it a patch? Is it a, vaginal estrogen, etc. I've had quite a few. It happens more commonly. So if you're this person, I want to tell you, you are not the odd man out. It happens to a lot of women. I've had women who are more the sensitive Sally. I've heard other clinicians call it your sensitive Sally, and we're going to have to go a lot slower. We might even have to decrease your dose. I've had that happen with progesterone in particular, where we start on 100 and that's a pretty typical starting dose. You can't go any lower. If you're getting progesterone from a regular pharmacy, you can't go any lower than 100. But for some women, that's too much. And so we have to go the route of getting progesterone from a compounding pharmacy and getting like a 50 milligram dose. I've had a number of women who that dose does much better for them. The other thing that we've had to adjust at times is adjusting the route. So for some women, taking that progesterone by mouth, just really like if they're more sensitive, it just knocks them out. It like makes them feel groggy, makes them feel, you can have bloating. You can even have increase in acne when you're on progesterone because of it causes some dilation of the pores and you can have some increased acne. Just to let you know, unfortunately, that can happen. So there may be some time of a period of adjusting that has to happen before you find that nice dose that works well for you and the formulation that works well for you. Another thing, I didn't bring this up on the risks one, and I meant to, was looking at the type of testing that you want to do. So, yes, we can just go off of, we can check blood levels and see where things are at. But what can happen is there can be some variation. I actually had this happen with a patient today. Her HRT is prescribed by another provider, but she sees me for other things, and her OBGYN has prescribed her estrogen patch. She is on a 0.375, and she was having more hot flashes. So they increased her estradiol patch to a 0.05 milligram. And she had blood work done probably 2 months, so about 8 weeks after that increase was made. And her estrogen actually went down on the labs. She had an estradiol of like 50 to 60 prior to that. And then when they checked it 2 months after her patch increase, her estrogen was down to 19. And so one conversation I had with her is like, let's just make sure this is accurate. If she is easily able to go to the lab and get, quick blood draw for estrogen. We had to check a few other things that weren't tested. And so we're going to recheck and kind of validate and see, okay, was that real? Is her estrogen only like 19? Maybe her body wasn't making some more estrogen previously and now it's not. And so the patch just isn't enough to make up for what her body's not making. But we're going to kind of recheck and see where that's at. But another thing to look at is there's other ways of testing. We use a monitor called the Mira in our practice. Sometimes our perimenopausal women actually benefit from this really well. Just those women where we may be titrating their dose. We might be, okay, let's bump up your estrogen a little more. It's still not high enough. It is a test that you can do at home. It's a urine test. You have your own little monitor at home. And I use it myself. My team uses it because we're all in perimenopause. But you can check levels like frequently throughout the month. The Mira was first used in like fertility patients that were checking estrogen, progesterone, FSH, LH frequently. But then they saw utility in using it in women that are in perimenopause, where we're titrating their HRT, or we're looking to see, okay, you are dipping down. We need, first you were on progesterone, now we have to add in the estrogen. So I will actually put an affiliate link in the show notes. Note, yes, we do make a small commission off of that if you buy through our affiliate link, but I literally use this myself, and it helps me to titrate my HRT so that I know my levels are at the where they need to be in order to control my symptoms, and then also to give me those longevity benefits. So there's other ways to monitor. Again, Mira isn't like widely used yet. So you might talk to your doctor about it and they go, I don't really know about that. But the other thing to consider would be doing something called a Dutch test. I know if you're listening to this podcast, I would assume you probably have heard of Dutch testing before. But what I love about the Dutch test is, especially when you're on HRT, if you're postmenopausal, or if you're in perimenopause and your hormones are really low, I don't think it is advantageous, because we're just going to see, okay, you have low levels of hormones. But then if we say you do have low levels, we get you on HRT and we get your levels up to, an average, like a good dose where you should be having symptom relief, and, we're nearing those optimal levels. We can actually see how your body is processing that estrogen. We can see a big thing that will come up is your body metabolize estrogen in the liver, and we actually can see the different pathways that estrogen is moving down. And why this is important is because there's a protective pathway. It's called the 2-hydroxy E1. We want the majority of our estrogen going down that pathway. But then we have these other two pathways, the 4-hydroxy-E1 and 16-hydroxy-E1. And when those, especially when the 4-hydroxy-E1, when we have a lot of estrogen going down that path, it creates something called a reactive quinone, which essentially what we see is an association. It can go in the body if your body's not able to handle it and clear it up and use antioxidants to address that. It essentially can increase the risk of damage to the DNA, damage to tissue. We see an increased incidence of things like endometriosis, uterine fibroids. You can see breast fibroids. So I think this can, especially if you're a woman who is really concerned about that cancer risk, looking at not only just what your estrogen levels are, but what your body is doing with that estrogen can tell you so much more about your risk. And the great thing is you can do things, say you do, that is controlled by a genetic variant many times, some lifestyle things, but often it's a genetic variant where you would essentially push more estrogen down that bad pathway, for, just a simplistic term. If you're pushing more estrogen down that pathway, we can actually use targeted supplementation that helps your body shift estrogen down the preferred pathway. It's something you probably can see it in many hormone supplements, something called DIM or I3C. But then the other thing is that we've got phase 1 metabolism, and then we have phase 2 metabolism in the liver. And we can actually see what that looks like on a Dutch test as well. So essentially, you don't want estrogen to get backed up in the system. You want your body to be able to clear it. And I've seen that happen before where women are on HRT. All of a sudden, doctor checks their estrogen. They've been on estrogen for a while. Let's check and see how you're doing this year. Your estrogen is 600. Oh my gosh, what happened? And it could be more, not that the dose is too high because they've been on the dose, but their body's not able to clear it well. And that is where some of our risk factors lie. Okay. So again, looking at testing can then also help to kind of stratify our risk factors. And again, this is something you'd want to work with a provider, obviously, who's familiar with Dutch, who's more advanced with HRT prescribing, especially if you have some of those certain, things that put you at higher risk. But then the fifth thing, I kind of alluded to this already, is you want to be aware that there's variation. I think we know this intuitively. But like that woman I talked about that I saw today, she's going, why are my levels so low, even though we keep going up on my estradiol patch dose? And right, another woman could be on that same patch, that same dose, and have, a estrogen of 300, where hers is like barely getting over 50. That is where genetic variation can play a big role. How your body is set up to clear. I talked about this in the last episode, but your body has to make hormones. It has to transport hormones. You have to receive hormones at the cell, and then your body has to break them down and then clear them, right? Detoxification. And you've got genetic variants that affect all of those things. So it makes sense that you and your friend, who are like maybe the same height, same weight, like you feel like you're kind of, you're very similar, like you eat healthy, you guys work out together, whatever, maybe it's your sister. But if you've got different genes that affect how your body is processing your hormones, right, your strategy may have to be different, right? You might need a different route than she does. You might need different supplements than she does to help with your estrogen detoxification, right? There's multiple things going on that can affect how your body processes those hormones, and why, like my patient said today, why are the dose keeps going up and it doesn't feel like it's doing anything, right? The conversation we had was there's a genetic variant called ESR2. It affects your body's ability to receive estrogen at the cell. The other thing we don't have genetic testing on her, so I don't know if that's the case for her, but we talked about that obviously today. And I suggested that could potentially be one of the things going on. Women who have that ESR2 variant just need higher levels of estrogen to get that same effect. But then the other thing we could see, she had a Dutch test in the past. And what we saw was that she had really high methylation activity. So what that means, that's that phase 2 detoxification of estrogen in the liver. Looked like she's like dumping her estrogen out really fast. And that there may be one thing going on. There could be two things, one or the other could be going on, or both, that's just essentially making it harder for her to get to therapeutic levels of estrogen. And so we're going to work on addressing that, right? Let's see what's going on inside, how your genes are affecting your hormones, and then work from there. So I hope this episode is just giving you a better idea of what you can expect, what you should expect from your provider if you're maybe seeing a provider that's not addressing some of these things, and how you can get to feeling like the way you want to feel. Because I know if you're listening to this, it's because you're having symptoms and you just want to feel like yourself again. And it doesn't have to be super complicated, right? But it may take a little more work than putting you on one dose of HRT and that one worked. Great. Perfect. Right. I've even experienced that myself of, I started with 100 milligrams of progesterone and I still can't sleep at night. And of course there's other things going on, but I've now experimented with going up to 200 milligrams of progesterone. And so there just may be some titration that has to happen because your body is unique. Your body is genetically unique. Hence the whole premise of this podcast, Her Genetic Edge. So again, just in closing, before you start HRT, or if you're already on it, go to your doctor and bring up some of these questions. Think through yourself, like, what is my goal? Do I have risk factors that I need to think about? Like maybe do you have a family history of dementia or a family history of osteoporosis or osteopenia or heart disease, right? Knowing that those risks are ahead of you can then influence like where you're going with your HRT. And again, just like you wouldn't get in the car and go want to drive and get up and get to a particular destination, you'd look at all of those things, the same thing you want to do with your HRT. So if this episode was helpful, please make sure that you're subscribed to Her Genetic Edge podcast so that you do not miss future conversations about genetics, hormones, and the root causes behind unresolved symptoms in midlife. You can subscribe on any of the podcast platforms, but I'd invite you to subscribe over on Substack. You can go to laurieaikman.com to subscribe so that you don't miss out on the other resources that we put out every week. All right, I will see you in the next episode.